Hello and welcome to the topic Actinic Keratosis in the Dermatology module. By the end of this topic, you should be able to define actinic keratosis, explain the pathophysiology of this disease, outline the causes and classification of actinic keratosis, describe the clinical manifestations, outline the investigations, discuss the principles of management, and discuss the complications and prognosis of actinic keratosis. Let's get started. Actinic keratosis, or AK, also known as solar keratosis, is the precancerous scaly spots that are seen on sun-damaged skin. Actinic originates from the Greek term actis, which means ray. It may be UV rays from the sunlight or UV lamps, while keratosis is made of kerat and osis, which means growth of keratin on the skin or on mucous membranes that is stemming from keratinocytes. Our skin is made out of epidermis and dermis. Epidermis consists of stratified squamous epithelium, which are keratinocytes in progressive stages of differentiation. Layers of epidermis are stratum corneum, the absorptive layer, stratum lucidum, which is only found in thick skin, stratum granulosum, also known as granular layer, stratum spinosum, the prickle cell layer, and the germinative layer known as the stratum basale. Epidermis function as a physical and biological barrier to prevent penetration by irritants and allergens. Dermis is the inner layer of the skin and it's much thicker than the epidermis. Its function is to protect and cushion the deeper structure from mechanical injury, providing nourishment to the epidermis and for wound healing. Overall, the skin is essential for protection as it forms a protective barrier to protect us from the mechanical, thermal, and other physical injury, as well as harmful agents, excessive loss of moisture and protein, and harmful effects of UV radiation. Skin is also needed for thermoregulation by altering blood flow through the cutaneous vascular bed. Lastly, skin is the organ that provides sensation to our body. Prolonged and excessive UV radiation exposure causes p53 gene mutations. p53 is a protein that stops cell with mutated or damaged DNA from replicating, and when mutation occurs, it becomes non-functional. This results in cells with damaged DNA due to UV radiation being able to replicate without control. Inflammation and immunosuppression also lead to intraepidermal proliferation of dysplastic keratinocytes, resulting in actinic keratosis. Actinic keratosis is a result of UV radiation to the skin, which is accumulated over a lifetime. It may be a result of genetic mutation, such as p53 or idiopathic. It is more commonly seen in immunocompromised individuals too. Actinic keratosis is classified according to its characteristics. Classic AK is white with scaly macule or papule. It can be plaques or various thickness and often with surrounding erythema that's about 2 to 6 millimeters in diameter. Hypertrophic AK is also known as hyperkeratotic AK. It has thicker scales, rough papules or plugs that's adherent to erythematous base. Atrophic AK is often less than 10 millimeters, smooth and not palpable, but there will be change in color, such as redness. If lesion has a conical shaped keratin projection with height of at least half a diameter, it is known as actinic keratosis with cutaneous horns. Pigmented AK has macules or plugs that are tan to brown in color. Actinic cheilitis more commonly appear on the lip as rough, scaly patches. There will be sensation of dry mouth and splitting of the lips. Bovinoid AK is often solitary and erythematous. It has scaly patch or plugs that is well defined. Patients commonly complain of pruritus, pain, and bleeding even with minor trauma. The lesions are found on the head, face, scalp, neck, dorsum of the forearms, and hands. Upon examination of the lesion, it has white scaly plugs with variable thickness and redness. The lesion has sandpaper-like texture and pigmentary alterations such as yellow or pale in color, surrounded by areas of hyperpigmentation. The skin is dry with deep wrinkles, coarse texture, purpura, and ecchymosis. The skin is dry with deep wrinkles, coarse texture, purpura, and ecchymosis. Scattered telangiectasia is present too. Investigations of AK require careful physical exams to look for all the signs mentioned. Dermoscopy or biopsy of the lesion will reveal strawberry pattern, which is erythematous vessel pseudo-network with prominent follicular openings and surrounding white halo. With photodynamic therapy, it will be positive, which is represented by presence of pink fluorescence. AK may remain unchanged, spontaneously resolve or progress to invasive squamous cell carcinoma. Hence, the treatment is generally decided based on the number of lesions present and the efficacy of the treatment available. All patients should be educated regarding limiting sun exposure. 5-fluorouracil is used to inhibit thymidylate synthesis and cause cell death in actively proliferating cells, while imiquimod upregulates the cytokines and invoke a non-specific immune response which include interferon, natural killer cells, and T cells. Topical diclofenac sodium 3% gel is used as analgesics. Photodynamic therapy uses topical application of a photosensitizer to the treatment area. Then exposure to this light source of specified wavelength, leading to generation of reactive oxygen species and eventual destruction of atypical keratinocytes. Surgical therapy is aimed to avoid progression of AK to squamous cell carcinoma and to reduce risk of recurrence. Modalities include cryotherapy that freezes the skin lesions through topical application of liquid nitrogen and curettage, or shave to remove hyperkeratotic AKs if unresponsive to alternative treatment. Surgical removal is done if diagnosis is unclear or there is high suspicion of squamous cell carcinoma. Dermabrasion requires a motorized handheld device with attached abrasive material to remove the superficial skin layers. Laser ablate the epidermis and superficial dermis, while chemical peels use topical application of a caustic agent such as trichloroacetic acid to remove the outer skin layers to desirable depths. Acute complications of AK are irritation, ulceration, bleeding, scarring, and cosmetic issues. Chronic AK can progress to squamous cell carcinoma. AK may spontaneously regress, remain stable, or evolve into invasive squamous cell carcinoma. To summarize, actinic keratosis is the pre-malignant cutaneous lesions that may progress to squamous cell carcinoma. It is a result of excessive and cumulative UV radiation exposure that induces change to the epidermal keratinocyte by disruption of regulatory pathways of cell growth and differentiation. Other risk factors include personal characteristics and genetic mutations. AK's lesions are irregular, red, scaly papule or plugs on sun-exposed body areas. It requires careful clinical examination and skin biopsy. Medical treatment of AK include pharmacological treatment, while surgical treatment is aimed at destructing the lesion. We have come to the end of this topic. Thank you.